No, but. Yeah, you want to say hello, or we do?
Yep, hello. Good morning and welcome to the Department of Medicine Grand Rounds. To introduce our speaker today is the Chief of the Division of Infectious Diseases, Keith Kay.
Thank you all. It's my distinct honor to welcome Dr. Alan Tunkel to give Medicine Grand Rounds today. Alan is a professor of medicine and medical science at Warren Alpert Medical School at Brown University. Alan is originally from Linden, New Jersey, so all roads always lead back to Jersey. And he got his PhD and MD from UMD-NJ in 1980 and 1984, respectively, where he was elected to AOA. He did residency and chief residency at the Medical College of Pennsylvania, and he did his infectious diseases fellowship at University of Virginia. He initially was interested in pathogenesis and pathophysiology of meningitis and CNS infections, which has led to lifelong expertise in that area. He's widely published. He's chaired the IDSA Practice Guideline Committee for Bacterial Meningitis, Encephalitis, Ventriculitis as well. He was previously at Drexel University College of Medicine, where he was director of the residency program, vice chair of the Department of Medicine, associate dean for admissions. I could keep going on, but I won't. I want to give him a little time to talk. He also was chair of internal medicine at Monmouth Medical Center in Long Branch. So Alan, he keeps coming back to New Jersey. That was June 2013. He subsequently went to Brown, where he began his appointment. He retired in 2022 as a senior associate dean for medical education. He was the PI in a large educational grant. In retirement, it's only a semi-retirement. He does a lot of cruising, but he also continues to see patients around, where the residents refer to him as Uncle Tunkel, which I think is awesome. He continues to teach, lecture, is leader in mixed-app development, and is a co-editor for Clinical Infectious Diseases, where he runs the state-of-the-art reviews section. I'm going to stop there and turn it over to Alan. All right, thanks, Alan.
Thanks very much, Keith, for that introduction. It's really a pleasure to be here. I have lectured here before. I was saying that maybe it was more than 20 years ago, but it's a pleasure coming back. And I've known Dr. Kay since he was in high school, I think, because I did my residency where his father was chair of medicine, one of my mentors in moving forward. And Keith used to do research, I think, in his lab and some of the other labs there. So it's always a pleasure to catch up. So how do I advance this? 1 second. Oh, there we go. So I'm going to talk about the management of bacterial meningitis, and I'm going to talk about it from the guidelines perspective and talk a little bit about how we arrived at the guidelines, but a lot of new things have happened since that time. So the learning objectives you can look at your leisure. I just want to recognize this gentleman. This is Mike Sheld, who was my mentor at the University of Virginia. So I met Mike when I was chief resident at the Medical College of Pennsylvania. He came to give a grand rounds on bacterial meningitis and sort of hooked me into the field and working with him. And Mike had one of the premier bacterial meningitis labs in the world. And working under him and being mentored and advised by him really was, I think, very critical to my career moving forward. And I think it was probably my work with Mike that led the Infectious Disease Society of America to ask me to chair the Practice Guidelines Committee for the management of bacterial meningitis. Now, I want to acknowledge that these guidelines were published in 2004. There has not been any update since that time, and a few things have happened since that time. So that's why we're going to talk about best practices as well. To be honest, the ID Society has no interest in updating these guidelines right now. I have no idea why, but clearly, a lot of these folks, I think, were critical in helping us move this forward. So the objectives of the guidelines are to provide clinicians with evidence-based recommendations for the diagnosis and management of bacterial meningitis. And these patients are obviously seen by primary care physicians, maybe even more often by emergency medicine physicians, and other specialists get brought in, infectious disease consultants, neurologists, and neurosurgeons. The other important note about these guidelines is that a lot of the data, there's not a lot of clinical data, so we defined a lot of it through experimental animal models of infection. So this is just to remind me and all of you that some of the recommendations I'm going to put forward are from experimental animal models. I'll tell you what was available in patients in terms of thinking how we approach this disease that can be very devastating. So let's begin with a case. So this is a 56-year-old female who presented with a 2-day history of fever, chills, headache, and confusion. You can see she's febrile, tachycardic, tachypnic, and hypotensive. She, on presentation, was obtunded, had a stiff neck, and had a purpuric rash on her lower extremities. I'm going to show you a photograph of that in a minute. Her peripheral white count was 30,000 with a lot of bands, and her platelet count was 40,000. So this is what her lower extremities look like. You can see she had a very diffuse purpuric rash, more purpura than normal skin. So let's use the guidelines a little bit to talk about how we're going to manage this patient who has presented to the emergency room. So I'm going to put forth 5 questions that we're going to try to answer and use the guidelines as a guide. So the first question is, we think this patient likely has acute bacterial meningitis. So should this patient undergo CT scanning of the head prior to lumbar puncture? So these are the usual clinical features of acute bacterial meningitis. So I think this patient is probably a very clear case. The most common symptoms and signs are fever, headache, stiff neck, and altered sensorium. You can see they're found in the majority of patients with acute bacterial meningitis, but actually less than half of these patients will have all 4 of these findings at the time they present, although more than 95% will have at least 2 of them. They may have increased intracranial pressure, so vomiting and seizures. All the books talk about Koenig and Brzezinski signs, but in adult patients with acute bacterial meningitis, these signs are only elicited in about 5% of patients overall. The point is, and for the residents and students, you should look for them, but their absence never, ever excludes the diagnosis of acute bacterial meningitis. Now, what about the lumbar puncture, and why do we even talk about neuroimaging before we do it? Well, there are a number of complications of lumbar puncture. Probably the most common is headache. So headache is seen in about 10 to 25% of patients after lumbar puncture. And it happens because when you do the lumbar puncture and withdraw the spinal needle, there can be a cerebral spinal fluid leak at the site of where you did the lumbar puncture. And the relatively low CSF pressure that results can give a pretty severe headache, and it's positional. When they lift their head off the bed, the headache gets much worse. Fortunately, the headache resolves over 24 to 48 hours in the vast majority of patients. There can be other findings as well, painful paresthesias, local bleeding, local hematomas, but the most important one is the last one, brain herniation. And the reason that you worry about brain herniation is that in someone who presents with a central nervous system presentation, the question is, do they have acute bacterial meningitis or might they have a mass lesion? So if you have a mass lesion, it's surrounded by cerebral edema, there's midline shift, there's relative downward displacement of the brain against the brain stem. And if you withdraw cerebral spinal fluid, you run the risk of brain herniation, a very devastating complication. How many people in the audience have ever seen brain herniation after a lumbar puncture? All right, I'm the only one, and it is really very devastating. So this is a very, very rare complication of a lumbar puncture, probably even in patients with mass lesions, but when it occurs, it's very devastating. So we wanted to determine who should get neuroimaging before they have a lumbar puncture. And this is obviously an older study. It's out of the Yale group where they retrospectively looked at 235 patients with suspected meningitis who had a CT. About 25% of them, it was abnormal, 5% with mass effect, and they identified features at baseline that most likely predicted that the patient might have a mass lesion if they were older, over the age of 60. I guess that was something they identified, but I don't understand why that would be significant. If they were immunocompromised, because immunocompromised patients such as those who may be HIV positive, transplant patients on long-term steroids, it just may be a little more likely that their presentation may be related to a mass lesion, if they have any history of CNS disease, or if they had any neurologic abnormalities on their exam. They then prospectively looked at the next 96 patients who had none of those features who underwent a CAT scan. 93% had a normal scan. Only one had mass effect. All 96 actually had a lumbar puncture without evidence of brain herniation. So I think, some of that validated, I think, what people do. So when we developed the guidelines of who should have a CT scan prior to lumbar puncture, these are the things we came up with. If they were immunocompromised, HIV positive, transplant, long-term steroids, any history of CNS disease, new onset seizures in adults, because maybe that predicts those who might have a mass lesion, altered consciousness where you really couldn't evaluate them, papilledema. So if actually anyone even does fundoscopic exams anymore, if you see papilledema, you probably should not do that lumbar puncture without neuroimaging, and any focal neurologic deficit. And our part of the guidelines are what we recommended. If all of these were absent, you could go ahead and do your lumbar puncture without getting a neuroimaging study. The reality of life, though, is that probably every emergency room in the country has a CAT scanner there. You can probably get the CAT scan, you get the results in about 10 or 15 minutes. So it probably gets done a lot more than is really needed. But this, I think, is a good guide and maybe modified a little bit if we ever do some updates to these guidelines. Let's move on to the second question. What specific cerebrospinal fluid tests will aid in the etiologic diagnosis of bacterial meningitis in our patient? So this is what spinal fluid can look like when they have meningitis, bacterial meningitis. It's cloudy. Cloudy usually due to the presence of numerous polymorphonuclear leukocytes, although very high concentrations of bacteria or high concentrations of protein can also make your spinal fluid cloudy. And these are the typical cerebrospinal fluid findings. So opening pressure is elevated. Usually it's up to about 180. So it's elevated because patients have cerebral edema, increased intracranial pressure. The white count should normally be less than 5 cells per cubic millimeter. In bacterial meningitis, it's about 1,000 to 5,000. Range can be very broad, though. You can have more than 10,000 white cells. You can have less than 100 white cells. It's usually a neutrophil predominance. The protein, which is normally about 10 to 45, is elevated. Why? Because the blood-brain barrier breaks down, so large molecular weight proteins can now travel from the blood to the brain. The glucose is low, but you always want to compare a spinal fluid to a simultaneous serum glucose. That ratio is normally greater than 0.6, so it's decreased in people with bacterial meningitis. So let's get back to our patient that I presented earlier. So her opening pressure was 280 millimeters of water. White count was elevated, 2,500, almost all segs, no red cells. Glucose was low, the ratio was low, and the protein was 400. So all very, very abnormal. So in terms of thinking about what the etiology can be, I'm going to talk about a test that's out there. I'm not sure how much this is done now on the floors, but certainly something to think about in trying to determine that etiology. And that test is called a Gram stain. So Gram stain, very, very important to do in patients you think might have acute bacterial meningitis. So this is the Gram stain of this patient. And you can see numerous polymorphonuclear leukocytes and these gram-positive diplococci in this patient who had acute pneumococcal meningitis. So I just said you should do the Gram stain. What's the evidence, though? So we need to at least look there. So Gram stain identifies a causative organism in the majority of patients. About 60 to 90% has a very, very high specificity. But the likelihood of the Gram stain being positive is going to depend on the concentration of organisms in the spinal fluid. So if you have greater than or equal to 10 to the 5th colony-forming units per mil, that Gram stain is going to be positive more than 95% of the time. If it's less than 10 to the 3rd colony-forming units per mil, it'll be positive less than 25% of the time. So it may depend on the pathogen, more likely to be positive with organisms like Streptococcus pneumoniae, Neisseria meningitidis, better to see, and if the patient's gotten prior antimicrobial therapy. But for some organisms like Listeria monocytogenes, that Gram stain is positive only in about 25 to 30% of patients. False positive results, observer misinterpretation, reagents can get contaminated, spinal needle can get occluded. So if it's occluded and you do the Gram stain, maybe a little staph from the skin got into that Gram stain that you're doing. But the truth of the matter is Gram stain is rapid, inexpensive, highly specific, so it should always be done on all cerebrospinal fluid specimens. But, what if it's negative, or what other things could suggest an etiology, a bacterial etiology of meningitis? So some other tests that have been done on spinal fluid is measuring the cerebral spinal fluid lactate. And you can see that based on the study, it has pretty good sensitivity and specificity, but a little lower in people who've been treated with antimicrobial therapy. And some of the studies are a little disparate in terms of the results. The principle is that when you have bacterial meningitis, you have cerebral edema, increased intracranial pressure, decreased blood flow to different areas of the brain. So that's one reason the glucose goes down. Glucose gets metabolized by glycolysis, and lactate levels can go up. But probably lactate, again, I would say the data are mixed. They also looked at certain proteins like procalcitonin or C-reactive protein. So these, if they are normal, may go against the bacterial etiology. In fact, for serum C-reactive protein, there was a negative predictive value of 99% in one study. But again, I would say the data are mixed. I just don't feel comfortable, given the seriousness of acute bacterial meningitis, taking measurement of one of these proteins in the blood is really being a good indication, or having good negative predictive value if they're normal. There is one study that looked at cerebral spinal fluid C-reactive protein, and this was published actually a couple of months ago. It's done in the European group, particularly the group in the Netherlands, and they have found that it works pretty well. They use the same test that is measured for serum C-reactive protein. So I don't know if it's really that valid on C-reactive protein. It was published. The aside is that it did not get published in the original journal to which it was submitted. I know that because I peer reviewed it, and I didn't really think that it was ready to move forward here in the US, but we'll see if more studies may help and make that determination. But let's really look at bacterial etiology. Obviously, you're going to culture all cerebral spinal fluid, so that's going to be positive in the majority of patients. In the old days, we used to do latex agglutination tests of cerebral spinal fluid. In fact, in our resident lab, we as residents did the latex agglutination test. But really, it's fallen out of favor. It's not done anymore. Same with this immunochromatographic test for Streptococcus pneumoniae. They just don't really alter how a physician is going to approach treating the patient. But tests that are out there are nucleic acid amplification tests, such as polymerase chain reaction. This is done single test, or broad-based PCR is used a lot, particularly in Europe, to try to determine the etiology. But I also want to talk specifically about the BioFire film array meningitis encephalitis panel. I'm assuming you have that test here, and it gets run on cerebral spinal fluid. So this lists the 14 organisms that are picked up by the BioFire film array meningitis encephalitis panel. Let me say up front, I'm going to give you some of my biases. I really have problems with this test. And the problem I have with it is that it's checking for these 14 pathogens. So you are sending tests to determine if one of these pathogens is present in a patient that may not have a clinically compatible illness. And that can lead to the possibility of getting false positive results. In fact, false positive results have been very well described for Streptococcus pneumoniae, one of the most common organisms that you're going to think about in your patient with acute bacterial meningitis. And maybe the specimens are getting contaminated, there's some cross-reactivity, maybe there's some issues with the reagents, but strep pneumo can give false positive results on the meningitis encephalitis panel. And some of the other organisms like E. coli, Haemophilus influenza, and Listeria can have negative tests, and patients can have meningitis due to these organisms. So at our place, we do not send this test immediately after we withdraw cerebral spinal fluid. We put a tube aside, and we might think about sending it if we don't determine what the etiology may be. And under infectious disease consultation, in getting this test, we can determine whether any results we get may be relevant. The other thing, particularly with some of the viruses like human herpes virus 6, I know this is a bacterial meningitis talk, but there are a lot of false positive results with human herpes virus 6 in the immunocompetent patient population. And even for herpes simplex viruses, the standalone tests are more sensitive than the meningitis encephalitis panel. So we, again, never send this up front. So let's move on to question number 3. How quickly should antimicrobial therapy be administered to patients with acute bacterial meningitis? So here's the algorithm that we developed that were part of the guidelines. So if someone comes into the emergency room, you think they have acute bacterial meningitis. So the first question you're asking yourself is, do they have any clinical features where you want to get a neuroimaging study before you do that lumbar puncture? So are they immunocompromised, history of CNS disease, new onset seizure, papilledema, altered consciousness, or focal deficits? If they don't have any of these, you can do your blood cultures, get your lumbar puncture stat. We actually recommended starting empiric therapy rapidly as possible, and then see if the spinal fluid findings are consistent with bacterial meningitis, and then you can direct your therapy. Now, if they have one of these and you're sending them to the CAT scanner, you want to get your blood cultures and then immediately begin empiric antimicrobial therapy. So the question for the guideline is, how quickly do you need to administer? They hit the ER, how much time do you have? Do you have 30 minutes, 1 hour, 2 hours, 4 hours, or do you wait for 24 hours? Do you have up to 24 hours to give it? So if you think about it, it's kind of an easy study to do. All of you in the audience come into the ER, you have acute bacterial meningitis. So on this half of the room, I'm going to treat you within 1 hour. This half, I'm going to wait 24 hours. And let's see what the outcome happens to be. Obviously, a study that's never going to be done given the ethical issues. But are there data to say how fast you need to give antibiotics? So not surprisingly, as I just mentioned, there are no prospective clinical data available. And the studies that we reviewed for the guidelines and things that have been done subsequently have really only examined duration of symptoms, not duration of meningitis prior to antimicrobial therapy. And for the guidelines, we reviewed 27 studies that were very heterogeneous, regarded demographics, study numbers, organisms, and length of follow-up. I want to talk about 2 studies, though. The first one is the last bullet here, which looked at outcome in the United Kingdom. So in the 1980s, in the United Kingdom, there were these outbreaks of meningococcemia, meningococcal meningitis, and obviously it affected a lot of young people. So the Ministry of Health instituted a policy that if any physician had a patient in which he, she, or they thought might have acute bacterial meningitis, they were supposed to give them an intramuscular injection of penicillin before sending them to the emergency department. So give it as soon as possible. And I guess if they saw them in their office, maybe it was on the subway, in the grocery store, whatever, they would carry that dose with them and give them that intramuscular injection. And what they found is in 305 patients from the UK, there was 1 death in the 53 patients who got that dose of an antibiotic before being sent to the ER, and 30 deaths, or 12%, in those who did not. Now, there definitely are problems with this study. It's a little retrospective, et cetera, but it certainly suggested that the earlier you give antibiotics, the better. Now, what do I think the best study is? And I recognize this is an old study. It was done by the Yale group, published in the late 90s, where they looked at 269 adults with bacterial meningitis, and they found that adverse clinical outcome was associated with the following. If the patients were hypotensive, they had altered mental status, or had seizures. So remember those 3 things: hypotension, altered mental status, or seizures. They then stratified the patients into 3 prognostic stages. Stage 1 was if they had none of those findings. They were not hypotensive, no altered mental status, no seizures. Their mortality was 9%. If they had one of those findings, 1/3 of the patients died. If they had 2 or more, 56% of the patients died. They then prospectively looked at outcome based on prognostic stage. So what this slide is showing you is what stage were they at when they presented to the ER, and what stage were they at when they got that first dose of antibiotic therapy. So stage 1, again, no hypotension, no altered mental status, no seizures. If they stayed there was adverse outcome in only 3 of 35 patients. If they advanced to stage 2, so had one of those findings, it was also pretty good in terms of adverse outcome. They still did okay. But if they went to stage 3, and again, numbers very, very small, but 3 out of the 4 patients had an adverse outcome. They started in stage 2 and stayed there, maybe about 1/3 of negative outcome. They went to stage 3, maybe about 60% did. So again, I think this is the probably the best study out there that really looked at something to give clinicians some guidance. So what were the guidelines? What did we came up with? So you want to give antibiotic therapy before the patient's clinical condition advances to a high level of clinical severity. When is that going to happen? When the patient comes in the ER? 30 minutes, 1 hour, 4 hours, or 24 hours? You have absolutely no idea. And from the guideline perspective, we thought the logical and intuitive approach makes sense. Time is brain. Once you have brain damage as a result of acute bacterial meningitis, it is not going to get better. But we felt there were inadequate data to find a specific time from the initial physician encounter to giving that first dose. And maybe we thought about this too, because, if we said 1 hour, and maybe you have to think about some of the medical legal implications, and really there's not particular data that's going to help us in these circumstances, we should not put that in the guideline. But the point is, give antibiotics as soon as you can, because that's going to be associated with a much better outcome. Next question. What specific antimicrobial agents should be utilized in patients with suspected or proven bacterial meningitis, or what should you give? So again, we go back to our algorithm. You think they have bacterial meningitis. If you're giving them empiric therapy, what should you administer before you send them to the CAT scanner? Even if you're going through the algorithm on the left side, they have bacterial meningitis, what do you administer if the gram stain is positive, or if it's negative, but their spinal fluid formula is still consistent with that diagnosis? So to be able to answer that question, I need to go through the common etiologies of community-acquired bacterial meningitis. So let me talk about them a little bit, and then we can talk about why we chose two specific antimicrobial agents. So the most common etiologic agent of bacterial meningitis in the United States is Streptococcus pneumoniae. It accounts for about 58% of cases. And think about pneumococcal meningitis, and people have other suppurative foci of infection. They have pneumonia, otitis media, sinusitis, head trauma with leak of cerebrospinal fluid. Because when that happens, you have a dural defect, so organisms can be transferred from the sinuses and into the cerebrospinal fluid. So again, always think about pneumococcus as being a common agent. The second most common, or the next important agent to talk about, is Neisseria meningitidis. Now it accounts for about 7% of cases. And these are the 5 serogroups we see: A, B, C, W, and Y. The 3 we see in the United States are really B, C, and Y. A accounts for a lot of the outbreaks you read about in sub-Saharan Africa, India, Nepal, and other areas. W has been associated with the Hajj pilgrimage. We're seeing in more recent outbreaks in the US, it's serogroup B. That's because based on vaccines that we have available for Neisseria meningitidis, the initial vaccine only covered serogroups A, C, W, and Y. So serogroup B led to outbreaks. Meningococcal meningitis, the risk can be increased in men who have sex with men. Their risk is 4 times greater in the general population. They're also HIV positive. The risk is 10 times greater. Those who take complement inhibitors that block C5, these inhibitors treat diseases like hemolytic uremic syndrome, paroxysmal nocturnal hemoglobinuria, neuromyelitis optica, a spectrum disorder. Their risk, if they're taking one of these drugs, is 1,000 to 2,000-fold greater than the general population. If they also, on the bottom, if they have congenital deficiencies in terminal complement components, these components are really critical for killing Neisseria species. They have a deficiency, their risk is 5,000 to 8,000-fold greater than the general population. So think about these risk factors when you're considering meningococcal meningitis. The third organism is Streptococcus agalactiae. This is really very rarely seen in adult patients. It's really an important etiologic agent in neonates, where it accounts for probably about 50% of cases. You can see group B strep in infants with early onset septicemia associated with prematurity or premature rupture of membranes. But people who get infected, these neonates can get a late onset meningitis, maybe beginning about a week after birth, increasing their risk to about 1 month. So disease, as I said, in adults is much less common. So let's talk about Listeria monocytogenes, an important organism that you need to think about in the adult population. You can see it's rare as an etiology of meningitis, but you think about it in certain epidemiologic circumstances. GI tract is the usual portal of entry. So outbreaks have been associated with consumption of contaminated coleslaw, raw vegetables, milk, these soft style Mexican cheeses, processed meat, cantaloupe, celery, hoghead cheese. Anybody know how to make hoghead cheese? Yeah, some people do. So maybe you know how to do that. If you don't, you can contact me after. I'll send you the recipe if you're still interested in making it. But the GI tract has been a portal of entry. Listeria is very common in neonates up to about 1 month. You can sometimes see it in young, previously healthy persons, but disease in adults, the elderly, purposes of bacterial meningitis, elderly is defined as over the age of 50 years. So remember that, because if I come into the ER and I have meningitis, you need to, or Dr. Fisher or Dr. K comes in with meningitis, you need to treat them for Listeria monocytogenes empirically until you get your culture results. But the important risk factors is malignancy, like hematologic malignancies, people on long-term steroids, things that impair cell-mediated immunity are a lot of the important risk factors. People getting anti-TNF agents are certainly at increased risk as well. Now, the last organism I'll mention is Haemophilus influenza, causes about 11% of cases. In the old days, capsular type B strains were the strains isolated in more than 90% of infections. There may be other sources of disease as well, and it's rare in people over 6 years of age. They may have other particular areas where they have Haemophilus infection, but I'm going to get back to this in just a minute. And this is why I'm talking about even Haemophilus here is this is the incidence of bacterial meningitis in the United States. So about every 10 years or so, the Centers for Disease Control and Prevention will do a surveillance study of cases of bacterial meningitis in the US, maybe of about 10 sites, maybe about 5,000 to 6,000 patients. Now you can see when the CDC did the surveillance study in 1986, Haemophilus influenza was the most common etiologic agent of acute bacterial meningitis. It accounted for about 45% of cases. Pneumococcus was number 2, meningococcus was number 3. When they repeated the surveillance study in 1995, you can see Haemophilus went from the most common etiologic agent to the least common. And this is due to the fact of the development and licensure of the Haemophilus influenza type B conjugate vaccine. So all infants and children are vaccinated at 2, 4, and 6 months of age with a booster at 12 to 15 months. And this vaccine is so effective, it's made invasive Haemophilus disease almost an endangered species in the US. I'll get back to that in a minute. So let me just make my, my political comment. See this slide? Vaccines are good. This is what the slide is showing. Vaccines are good and very, very important. So pneumococcus became number 1. You can see that in 2006, when they did the surveillance study again, Haemophilus went down more, probably because more use of the vaccine. Even pneumococcus started to decrease because in 2000, we had licensure of the pneumococcal conjugate vaccine, only covered, though, 7 of the serotypes, and there's more than 90 serotypes of Streptococcus pneumoniae. Meningococcus also started going down. That quadrivalent meningococcal vaccine that covers serogroups A, C, Y, and W was licensed in 2005, but was probably already going down even before that vaccine was used that much. And Group B strep stayed the same. Listeria went down a little, probably due to better food processing. But the CDC just published their next surveillance study. And again, I want to show you. So if you go back to sort of 2008, pneumococcus here in the red was still relatively high, began to decrease because we had development of new pneumococcal conjugate vaccines, licensure of a 13-valent pneumococcal vaccine. I think most of you know now we have a 20-valent pneumococcal conjugate vaccine that's recommended for children and adults. And there's even a 21-valent pneumococcal conjugate vaccine that covers even more of the serotypes that are seen in the elderly population. So pneumococcus, again, was coming down. It really dropped in 2020, 2021, but this coincided with the COVID-19 pandemic, and things sort of shot up a little bit after the pandemic. You can see, you can see a lot of the other agents stayed constant, but look here in the orange with Haemophilus influenza. So it went down again during the pandemic, and it's been going up. And we're seeing some more cases of Haemophilus meningitis due to non-serotype B strains as well as non-typable strains. So this again, is very, very important to monitor because maybe new vaccines or new things will be important to prevent this upturn. So the patient comes into the emergency room, you think they have acute bacterial meningitis, you decide to send them to the CAT scanner first before you do it. What antimicrobial therapy should you administer? So this is medicine grand round. So let me just talk about the adult patient population, thinking about adults greater than 18 years of age. So they should be treated with vancomycin and a third-generation cephalosporin, either cefotaxime or ceftriaxone. Cefotaxime is hard to get these days, but ceftriaxone can be used because the most likely organisms from the community are going to be Neisseria meningitidis and Streptococcus pneumoniae. If it's me, over the age of 50 years, you have to think about Listeria. They should get vancomycin and a third-generation cephalosporin, but these agents do not reliably treat Listeria monocytogenes, so you need to give these patients ampicillin as well. Vancomycin, ampicillin, a third-generation cephalosporin. What if the gram stain is positive? So if you're comfortable looking at your gram stain, if you see gram-positive diplococci, give them vancomycin, a third-generation cephalosporin empirically. I'll tell you why in a minute. If it's a meningococcus third generation, if you see gram-positive bacilli consistent with Listeria, I'd give them ampicillin or penicillin G. But I want to talk specifically about the approach to treating pneumococcal meningitis, because that's the most likely organism you're going to see. And in the old days, I'm talking about, the late 1970s, pneumococci were pretty uniformly susceptible to penicillin G. And then, but in the late 1970s, there began to emerge areas of the world in places like Spain and South Africa. We're seeing resistance of strep pneumo to penicillin. And this was because in these areas, you could buy penicillin over the counter, maybe indiscriminate prescribing led this to emerge as well. So right now in the United States, and it may depend a little bit on geography, probably about a third of pneumococcal strains are resistant to penicillin. For even third-generation cephalosporins, maybe about 10% may also be resistant. So I don't know what your data are here, but this mirrors at least what we are seeing in Rhode Island. So the way you define pneumococcal susceptibility to penicillin depends on the MIC, the minimal inhibitory concentration. So it's considered susceptible if the MIC is less than or equal to 0.06, resistant if it's greater than or equal to 0.12. Now, here's why this is important for bacterial meningitis, because if any of you came into the ER and you had acute bacterial meningitis and I treated you with high-dose intravenous penicillin, and I measured the concentration of penicillin in your spinal fluid, I could get 1 microgram per ml. That's the best concentration I can get. So if under these susceptible organisms, I'm getting plenty of penicillin into your spinal fluid to inhibit and kill the organism. But if you have a resistant strain, maybe it's even greater than 1 or greater than 2, I cannot get enough penicillin into your spinal fluid to inhibit and kill that pneumococcus. So when we developed the guidelines, our approach was in all of your patients with pneumococcal meningitis, you should treat them with a combination of vancomycin and third-generation cephalosporin under the assumption that they have one of these penicillin or even cephalosporin-resistant strains. Once you do susceptibility testing, if it's susceptible, you can actually treat them with penicillin, if anybody knows how to use penicillin anymore. If it's resistant, if it's sensitive to third-generation agents, you can give them ceftriaxone. But if it's resistant to both penicillin and ceftriaxone, you want to continue combination therapy. What's the clinical data to support this recommendation? There isn't any. There has never, ever been a clinical trial that has shown that this combination is the best agent for treating resistant pneumococcal meningitis. This is based on an experimental rabbit model where this combination was synergistic in eradicating resistant pneumococci from the spinal fluid. So just be aware that the data are not particularly good. And if it's meningococcus, treat them with a third-generation agent. You should do susceptibilities because we're seeing actually more meningococci that are resistant to penicillin. And if it's Listeria, again, ampicillin or penicillin, I add an aminoglycoside at least until the patients have clinical improvement. All right, we are now getting to the last question in bacterial meningitis. What is the role of adjunctive dexamethasone in patients with bacterial meningitis? So these are the case fatality rates of bacterial meningitis. So I took this overall. This is from the data that were just published by the CDC within the last couple of months. And you can see the case fatality rates are really not that great. I mean, they actually have come down a little bit in recent years, but to be honest, it's even worse in many developing areas of the world where there may be inordinate delays from the patient presenting until they get that first dose of antimicrobial therapy. So some improvement compared to past studies. But even though we think about the diagnosis, we give antibiotics as rapidly as possible, people still die from their infection. And to understand, how we use adjunctive dexamethasone, you have to understand how somebody gets bacterial meningitis and what happens after they get it. So this is obviously a schematic. So this is the blood up top here. This is the brain, or maybe more likely subarachnoid space or cerebrospinal fluid. And this is the blood-brain barrier. The blood-brain barrier has these intercellular tight junctions that keep these large molecular weight proteins out or do what they can to protect the brain. So you have bacteria circulating in the blood, and they attach to the cerebral microvascular endothelium that make up the blood-brain barrier, and they're transported across these cells into the cerebrospinal fluid. So as these bacteria, once they get in, they begin replicating. Bacterial meningitis is an infection in an area of impaired host resistance. There's very low concentrations of immunoglobulins and complement, so the bacteria really can replicate unchecked. So as they're replicating, they're starting to release their virulence components. Gram-negatives are releasing lipooligosaccharide, gram-positives are releasing their cell wall. So these virulence components are acting on cells in the nervous system like macrophages to produce inflammatory cytokines like interleukin-1, interleukin-6, and tumor necrosis factor. And these cytokines act on cells of the blood-brain barrier to disrupt the intercellular tight junctions, and now white cells can migrate from the blood into the brain. Now, so white cells are migrating in a very positive way. And if you think about it, this process is very good for controlling infections in other parts of the body. But what we've learned in people with bacterial meningitis is that when you treat them with antibiotics, you make this inflammatory response much, much worse. And by that, I mean the bacteria get in, they're slowly releasing their virulence components. You treat them with an antibiotic like ceftriaxone that's going to lyse apart all the bacteria, leading to an augmented release of these virulence components, acting on macrophages, really increasing the release of inflammatory cytokines. So whereas if you get an infection in your hand, it gets hot, it's uncomfortable, white cells are getting in to try to control the infection. At the brain can't expand. It only has within the cranium, it only has one direction to go but down. So that certainly may contribute to worse outcome. And let me use an illustrative case. This was a patient I saw many, many years ago, actually when I was a junior attending, an elderly gentleman who came into the ER with acute bacterial meningitis. And he had a CAT scan of the brain. This is his initial CAT scan, which was read as normal. So here's the cranium. You can see, these are the lateral ventricles. You can look under the cranium. You see these sulci. And we thought about the diagnosis early. We treated him with appropriate antibiotics, but he did not wake up. And this is what his brain looked like 3 days later. So again, here's the cranium. You don't see any sulci now under the cranium. His lateral ventricles are totally compressed. He had cerebral edema, increased intracranial pressure, went on to herniate and die from his episode of acute bacterial meningitis. And this is a different patient, but this is an autopsy specimen of a patient who had acute bacterial meningitis. And you can see this very thick, purulent exudate that's on the base of the brain. And if you look at it histologically in the sulci, it's packed with neutrophils. So the inflammatory response can be very, very important in worsening outcome in patients with acute bacterial meningitis. And I want to illustrate this in this particular slide. And this is an experimental rabbit model. And let me just take you through some highlights of this. So just look at the bottom panel. So on the y-axis is white blood cells and cerebrospinal fluid. X-axis is time. So an experimental rabbit model of Haemophilus meningitis. So at time 0, the rabbit gets an intracisternal inoculation of Haemophilus influenza, and you're following the white cell count in the spinal fluid with time, and you can see that it slowly goes up. So the second experiment is they get the intracisternal inoculation, but at 6 hours, they're treated with an antibiotic like ceftriaxone that's going to lyse apart all the bacteria. And what you see is a
really an augmentation of this inflammatory response in cerebrospinal fluid. Now, at 6 hours, if you give them the antibiotic, but also give them an anti-inflammatory like dexamethasone, you have an attenuation of that response. So these and other experimental studies led to many, many clinical trials that looked at adjunctive dexamethasone in patients with bacterial meningitis. So we looked at a lot of the clinical trials, and it's important to note that clinical trials were variable. Not all were placebo-controlled. A lot of different antibiotics were used in the trials, antibiotics that were subsequently shown to be inferior for the treatment of acute bacterial meningitis. Dexamethasone was administered at different times in relation to the first antimicrobial dose, with the notion that if you gave dexamethasone after antibiotics, maybe you couldn't get great attenuation at that response, and patients had varying levels of illness severity. But the major study in adults was published in the New England Journal of Medicine in 2002. It's called the Dutch study because it was done in the Netherlands, where they looked at 301 adults with acute bacterial meningitis. It was randomized, double-blind, placebo-controlled. They got dexamethasone at the dose shown that was given 15 to 20 minutes before that first antimicrobial dose. How they come up with that dose, I think it's kind of made up. It's like the neurosurgery dose that's always used, but whatever. And what they found that when they looked at all patients, those who got adjunctive dexamethasone had a statistically significant reduction in unfavorable outcome and mortality, and particularly in the subgroup of patients who had acute pneumococcal meningitis, that was the group where they really saw the most significant benefit in terms of reduction, unfavorable outcome, and mortality rate. So before this study came out, I did not recommend adjunctive dexamethasone in adults. This study actually convinced me. And Mike Sheldon and I wrote the accompanying editorial that went with this paper in the New England Journal of Medicine, where we recommended use of adjunctive dexamethasone. So why do you give adjunctive dexamethasone? It attenuates the subarachnoid space inflammatory response. It's recommended in infants and children with Haemophilus and considered for pneumococcal meningitis in childhood. Not all pediatricians endorse it for pneumococcal meningitis. I think they're wrong, but I actually purposely picked a pediatrician on the committee who I know is not a big dexamethasone advocate. But you want to give it. There's the dose every 6 hours for 4 days, concomitant with or just prior to that first antimicrobial dose. So we felt that giving it soon is very, very important. Now, the caveat I will give you is that in our guidelines, well, let me raise the other question maybe that you're thinking about. If they get antibiotics, when can you give dexamethasone after that first dose? Is there a time frame where it still may be beneficial? I'm not sure it's been defined. I will tell you that in the European guidelines, they say you can give it up to 4 hours after that first antibiotic dose. It's made up, though. It really was, again, a consensus by experts in the field. I think probably if you wait longer than an hour or so, I'm not sure it's going to be beneficial. But there have been a lot of meta-analysis that showed decreased mortality in adults, particularly adults with pneumococcal meningitis. So it really has shown benefits, and I think really it should be administered to all patients with suspected or proven acute bacterial meningitis. And in fact, this is a surveillance study. This is an epidemiologic study that was published about 10 years ago. And on the y-axis, they're looking at rate of in-hospital mortality in patients with acute pneumococcal meningitis with year of study. So here's their mortality rate. And then here, 2002, the Dutch study got published, and our editorial got published where we recommended adjunctive dexamethasone. And then when we published, and you can see the in-hospital mortality began to decrease. And then in 2004, we published the guidelines where we recommended in all adults with acute pneumococcal meningitis, and things went down even further. Now, I should say this is an epidemiologic study. I actually have no idea how many of these patients actually got adjunctive dexamethasone. And data in the US is really that only about 40% of patients actually get it. But similar findings have been seen in the Netherlands, where 85 to 90% of patients get adjunctive dexamethasone. And what about other etiologic agents like listeria? Well, this was an area of controversy because of a study published in Lancet ID, a French nationwide prospective cohort study of patients with acute listeria meningitis, where they actually showed increased mortality with administration of adjunctive dexamethasone. But only 13% of patients got it. There was nothing in the study that said what the timing was. We don't really know if they got it before or after antibiotics. Some may have gotten it even more than 24 hours after that first dose, or maybe when they were more severely ill. That Dutch group then did a prospective cohort study in their patients. Many more of them got adjunctive dexamethasone, and they found that unfavorable outcome was higher in those that didn't get it. And a multivariate analysis showed increased risk of death, those who didn't get adjunctive dexamethasone. So I would give it. It makes sense really based on the pathophysiology. So I think it should be done. So you now think they have bacterial meningitis. Do you need to send them the CAT scan or first get your blood cultures? Give them a dose of dexamethasone along with that empiric dose of antibiotic therapy. If it's on the left side, blood cultures, lumbar puncture, stat, again, give them dexamethasone with empiric therapy. And depending upon your findings, that will help you decide whether you're going to continue adjunctive dexamethasone. So I am a believer. So my last slide, I just want to remind you, earlier this month was World Meningitis Day. It actually happens October 5th every single year. So this is a day that's really dedicated to global elimination of meningitis. How are we going to do that? Vaccines, vaccination, vaccination, vaccination. That's really going to stem the tide of acute bacterial meningitis further in the United States and throughout the world. So I thank you for your attention. Be happy to answer any questions. Thank you. Dr. Fisher.
Thank you. Marvelous presentation, Diane. One of the things I learned early in my career was sometimes you have to tell the lab to centrifuge is done before the gram stain. We had a patient with listeria whose uncentrifuged gram stain didn't show it. And while I was on our way to the hospital, they centrifuged it and it was loaded. So if there's a question about centrifuging it, make sure they do it. I think very strong.
Yeah, I would agree. Again, certainly it's going to increase the yield. You know, everything gets done in the lab now. Again, in the old day, I can't believe I'm talking about the old days. We had our own centrifuge. We had all of our reagents. We did everything ourselves as residents, but can't do that anymore. But it is what it is.
I saw that some of your slides mentioned rifampin use in some cases with dexamethasone use or increased MIC. Is that one of your recommendations, and should we be considering that? Is it third line covers for bacterial meningitis? And I guess another question, so the second part is that should we consider that in patients with recurrent meningitis with a higher risk for resistant organisms?
Yeah, so I think the rifampin question is really a very good one. And I think, so I don't use it empirically in patients with acute, who I suspect acute pneumococcal meningitis. So I think obviously you want to do susceptibility testing to know whether it's susceptible, but at least in experimental models with dealing with resistant organisms or they're not responding as rapidly as you want, rifampin, which penetrates well into cerebrospinal fluid, is something that, you know, you should consider adding. And again, I think I would only add it if it's susceptible and the patient is not responding as expected. If they have recurrent bacterial meningitis, I don't know that I would necessarily add rifampin. You know, again, I would base it on what the clinical response is. Dr. Kale. Oh, go ahead.
Thanks. So great talk. Question about the steroids. Is there any thought or concern about the steroids decreasing meningeal inflammation and then subsequently decreasing antibiotic penetration?
Yeah, I think that's also an excellent question, which we also addressed in the guidelines. And I think where we think about this a lot more is in patients who you may be treating with vancomycin. So vancomycin penetration can potentially be decreased in patients in whom you're treating for acute pneumococcal meningitis. But it raises the point that, and what we have found in the literature, is that where it decreases penetration, they haven't used appropriate doses of vancomycin. So you want to give appropriate doses where you're getting serum trough concentrations of 15 to 20, or if you do area under the curve, do you do area under the curve here? Which we actually don't do in Rhode Island, believe it or not. You want to get in the 400 to 600 range to be sure you're getting adequate concentrations in cerebrospinal fluid. we wondered whether it would be maybe the Dutch folks would follow up because in their study, they didn't have a lot of patients who had resistance, pneumococcal resistance to penicillin. So, but it's another study that I'm not sure is ever going to be done. It took the Dutch investigators 9 years to enroll their 301 patients for the trial. So we may not have a definitive answer, but I think the key is giving enough vancomycin to do it.
So Alan, excellent talk. So I have two questions. The first, guidelines sometimes are catch-22. So steroids are recommended for pneumococcal meningitis, but the period when you would give them, you wouldn't know that they had pneumococcal meningitis. So a practical application would be in severe meningitis where you suspect bacterial meningitis. That would be a good time to consider steroids. Is that accurate?
Well, I would give them to all patients with acute bacterial meningitis. Again, I think the benefits really do outweigh the risk. When we published the guidelines, at least in adults, the data were only for pneumococcus. I think we have, some good, relatively good data for listeria. From a pathophysiologic perspective, I think it does make sense. So I don't think I would base it on severity. I think I would give it because the issue is if you give the antibiotics without steroids, maybe the level of severity is going to get a little worse. So I would give them.
The suspected bacterial meningitis.
Yeah, so I would just give them, again, there are data out there where they've looked at patients who got steroids and didn't have bacterial meningitis. So they were diagnosed with viral, they got the steroids, a couple of doses did not affect the outcome of those patients who did not have acute bacterial meningitis.
My second question is you showed trends in meningitis pathogens, and you showed sort of COVID effect. With pneumococcus increasing, is that because of the drop off in vaccination during COVID? And how about for H flu? Is that, you said it's non-typable now that's increasing, but is there a bump in type B that is vaccine preventable as well?
Yeah, so there's not. So it really seems to be, at least for Haemophilus, it seems to be for the ones that are not in the Haemophilus influenza type B conjugate vaccine. For pneumococcus, I don't think it's related to vaccination because the serotypes that emerged were in the 13-valent pneumococcal conjugate vaccine. So again, I would say probably most of those patients got it already. So I don't think it's really related to the vaccine. Obviously now everyone's getting the 20-valent vaccine. And maybe for the elderly, it'll be the 21-valent.
You have a question or anything online?
The CME code is 31623 for products. Thank you so much for the talk. Just to go back to steroids one last time. You mentioned the Europeans in the 4 hours, 1 hour. What is your opinion and expertise on steroids after the antibiotics are given? Let's say you get called the next day, proven bacterial meningitis. It's about maybe 12 hours since the antibiotics have been given.
No, I wouldn't give it. I'm not sure it makes sense to give it at that time. And so I'm sort of maybe within the hour category, I might still give it. When the folks from the Netherlands first presented the European data, they actually said, well, you could give it up to 12 hours. And so I got up and said, there's no data to do that, Diedrich. Like, how can you recommend? Well, maybe I was nice or maybe I wasn't, but I just am not sure the data are there. So I'm not sure that it really is beneficial at that point.
Thank you.
All right. Thanks again.
Thank you very much.
Wonderful. I just there's nobody who's faster.
Weeks in advance.
I don't think that's sort of more important thing. I'll make us start with it. No thought.
No, by someone right now. Okay.
He's the sugar.
Italy is working with you. Dr. Fisher?
So you're learning a little bit about gram-negative organisms and hospital.
You know our problem is.
What's the, how is it in Italy?
Would it be helpful who is coming to speak?
That, as you go south.
Yeah, the south you go, I'm gonna go to worse. Sounds like you set up this conference as part of that.
That's fine, I'm happy to take a look.
That's good.
I mean, part of it is, some of them I'm not.
Yeah.
I don't see much in Rhode Island. That's really interesting. I might just see.
Yes, resistant pseudomonas, I think a fair amount, that's what.
I'll have
that-
Title.
They are.
Really got.
Like, that's the
Obviously,
factor
Rod,
of the adverse, you see some scary, ESBL is probably 15% of E. coli.
So that's sort of, that's common.
Okay.
Not in Detroit, Michigan level, with the hotbed for resistance. We're doing it for me out there.
And then I don't know who else.
I think we're gonna go now.
I can
Just
just,
defend.
if you want,
Feed
all
up.
of us, do with them, if you want to do it one-on-one. and then
Wanna
one-
join us?
I'm gonna go upstairs and get the book, there was a book that was given.
Great.
Where are you going?
You know,
What special?
I want to go and see if the conference, yes, my office is open.
There's your office.
I'm right in the seventh floor here, the conference room next, if you guys, we get out of my office. Let's just try that, we'll come up with it.
Wants to meet with Jordan.
Because when you leave with Dr. Clark, she's near my office, Alan, save us some running around.
Thank you very much.
Okay.
Thank you.
You wanna make a field trip upstairs?
I'm going to go upstairs.
It's a very.
Yeah, great. Absolutely.
Thank you for being patient with that week. I was in.
I never got that W line or whatever. So.
Really? Oh, well, because we have to do candidates and after the talk, like we'll get it after today. I'll go ahead and process everything.
And I can send you, the only receipts I think I have.
That's fine.
Okay.
You can absolutely send that to me.
Thank you.
Thank you.
This is all over. You typically delete the downloaded presentations.
Oh, there was a message. Oh, well. That was a good question, man.